Welcome to this Step 3 review on Medical Ethics and Professionalism. This video is brought to you by Roadmap to Residency. Ethics questions are some of the most predictable points on the whole exam because the tested principles almost never change. What changes is the scenario dressed around them. Our goal today is not to reteach ethics from the ground up. It is to show you how these stems are built, which key phrases to hunt for, and how to walk from the vignette to the correct answer with confidence. We will cover informed consent, capacity, confidentiality, and the disclosure of medical errors. Keep your question bank and a trusted review resource open alongside this video, because these patterns lock in fastest when you drill them. Let us get started. Here is what we are going to cover today. We will work through the 4 ethics topics the exam tests again and again. First, informed consent, and the small number of elements a valid consent must contain. Second, capacity assessment, and how to decide whether this patient can make this particular decision right now. Third, confidentiality, along with the disclosure of medical errors, where you have to know exactly when to protect information and when to reveal it. Along the way, we will walk through several practice questions together and explain precisely why each answer choice is right or wrong. This video assumes you already know the baseline rules from your review resource. We are here to sharpen how you apply them under pressure. Our first topic is informed consent, and the key is to have a mental checklist ready before you even read the answers. Valid consent requires 4 elements. The patient must have capacity. The discussion must cover the risks, the benefits, and the reasonable alternatives, including the option of doing nothing. The decision must be voluntary and free from coercion, and the patient must actually understand what was explained. When a STEM asks what is missing or what you should do next, hold the scenario against those 4 elements and find the gap. The second idea to carry in is that consent belongs to the patient. A patient with capacity may refuse any treatment, even one that could save their life. Be ready for STEMs where a spouse, an adult child, or the medical team wants to push past a capable patient's refusal because they think it is unwise. The correct answer protects the informed, capable patient's choice. A family member's preference never overrules a capable adult. Our second topic is decision-making capacity, and there are 2 ideas that unlock almost every question. First, capacity is decision-specific, and it can change over time. The same patient may have the capacity to consent to a blood draw, yet lack it for a major operation, and delirium or intoxication can take capacity away temporarily and give it back later. Remember that any treating physician can assess capacity at the bedside. You do not need a psychiatry consult to establish it, so be careful with answers that reflexively call for one when the STEM already hands you the assessment. Second, judge the reasoning, not the choice. A patient has capacity when they can understand the relevant information, appreciate how it applies to their own situation, reason through the options, and communicate a consistent choice. The single most common trap is a STEM that pressures you to declare a patient incapable just because they made a decision the team dislikes. Disagreeing with the doctor is not a loss of capacity. Look at how the patient is thinking, not at what they decided. Our third topic is confidentiality, and it is best understood as a strong default with a short list of exceptions. The default is protection. Patient information is private, so when a STEM has an employer, a family member, a friend, or another physician asking for details without the patient's permission, the correct answer is almost always to decline and to seek the patient's consent before sharing anything. Then know the narrow exceptions, because this is where the points are. Confidentiality gives way when there is a serious and identifiable threat to a specific other person, when there is a reportable communicable disease, and when there is suspected abuse of a child or a vulnerable adult. If the STEM clearly matches one of those, then protecting the information becomes the wrong answer, and your duty shifts to warning, reporting, or protecting. Finally, watch 2 heavily tested wrinkles. Adolescents are frequently granted confidentiality for sensitive services like contraception, pregnancy care, and sexually transmitted infections. And when a patient with a serious transmissible infection refuses to inform an at-risk partner, the pattern is to counsel the patient first, while recognizing that a genuine risk to that partner can justify notification. Let us work through our first practice question, and it targets informed consent. A 62-year-old man with capacity is scheduled for elective gallbladder surgery. The surgeon explained the procedure and its benefits and had the patient sign the consent form, but nowhere in the note is there any discussion of the risks or of alternatives, such as simply watching and waiting. Then comes the key detail. In the waiting area, the patient tells the nurse he is not really sure what could go wrong. The question asks for the most appropriate next step. Before you choose, run the scenario against the 4 elements of valid consent and find the one that is missing. Read the 4 options carefully, pick your answer, and we will reason through each one on the next slide. Let us break this down. First, spot the gap. The consent process covered the procedure and its benefits, but it skipped the risks and the alternatives, and the patient openly says he does not understand what could go wrong. Held against the 4 elements of valid consent, 2 are missing here: full disclosure and genuine understanding. A signature on a form is not the same thing as informed consent. Now apply the rule. Consent is a conversation, not a piece of paper. Because disclosure and understanding are incomplete, the fix is to have the surgeon return and discuss the risks and the reasonable alternatives so the patient can make a truly informed decision. So, the correct answer is to have the surgeon discuss risks and alternatives before surgery. Now eliminate the others. Proceeding just because the form is signed ignores the missing elements entirely. Asking the patient's wife to decide is wrong, because a capable adult makes his own choice. And cancelling the surgery permanently badly overreacts, since the only problem is a fixable gap in the discussion. The correct answer is to complete the consent conversation first. Here is our second practice question, and it is all about capacity. A 70-year-old woman with a diabetes-related foot infection is advised to have surgery to stop the infection from spreading. She calmly explains that she understands she could lose her foot, or even her life, if she declines. But she has decided to refuse the operation and try antibiotics first. She lays out her reasoning clearly and consistently. Her thinking is not clouded, and her mental status exam is completely normal. The question asks for the most appropriate next step. The trap here is to let the seriousness of her choice pull you towards stripping her capacity. Instead, look at how she is reasoning. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, assess capacity, and assess it by the reasoning, not by the choice. Run the 4-part check. She understands the information she was given. She appreciates that it applies to her own body and her own life. She reasons in a clear and consistent way. And she communicates a definite choice. Her mental status exam is normal, and her thinking is not clouded. By every criterion, she has full capacity, and the fact that her decision is dangerous does not take that capacity away. Now, why does her refusal stand? Because a patient with capacity has the right to refuse treatment, even treatment that could save her life. That means forcing the surgery, declaring her incapable so her son can consent, and ordering a psychiatric hold are all wrong, because each one overrides a capable adult. The right move is to respect her refusal while continuing to counsel her, answer her questions, and keep the door open. The correct answer is to respect her refusal and continue to discuss the risks with her. Our fourth topic is medical errors and their disclosure. And this is one of the most predictable patterns on the whole exam once you know the rule. First, always disclose to the patient. When an error causes harm, the correct action is an honest, prompt, and direct disclosure by the responsible physician. If any answer choice hides the mistake, waits to see whether the patient notices, or hands the task off to someone else, that choice is wrong. The patient hears the truth, and they hear it from you. Second, own it, do not blame, and report. Proper disclosure includes an honest explanation of what happened, and, when appropriate, an apology, but it never means blaming your colleagues in front of the patient. The disclosure to the patient is about the patient. Separately from that conversation, you report the event through the hospital's safety or incident reporting system, because that is how the underlying process gets fixed and future errors get prevented. And if the STEM involves a colleague who made the error, the pattern is to encourage and support that colleague in disclosing it themselves. Keep those two moves together. Tell the patient honestly and report through the system. Here is our third practice question, and it tests confidentiality. A 35-year-old man is being treated in your clinic for depression. A week later, his employer calls you directly, explains that he has missed several shifts, and asks you to confirm his diagnosis and share his treatment plan so the company can make decisions about his job. The crucial detail is that the patient has given no permission whatsoever to release any information. The question asks for the most appropriate next step. Before you choose, ask yourself whether this situation matches any of the narrow exceptions to confidentiality or whether the default rule of protection applies. Pick your answer and we will work through each option on the next slide. Let us break down this answer. First, check whether any exception to confidentiality applies. An employer calling to ask about an employee's mental health treatment is not a serious threat to a specific identifiable person. It is not a reportable communicable disease, and it is not suspected abuse of a child or a vulnerable adult. None of the narrow exceptions fit, so the strong default rule holds, and the information stays private. Without the patient's consent, you simply cannot release anything. Now, the key distinction between the wrong choices, and notice that all three leak protected information in some form. Confirming the diagnosis outright is a clear breach of confidentiality. Sharing only the treatment plan while withholding the diagnosis still discloses protected information the patient never authorized. And telling the employer to ask the patient and then confirming still ends with you releasing details without proper consent. Every one of those options gives something away. The only correct answer is to decline to share and explain that you would need the patient's own consent before releasing any information. Here is our final practice question, and it brings the medical error rules to life. A nurse accidentally gives your patient double the intended dose of a medication. The patient now has a fast heart rate, but is stable and recovering well. The patient looks at you and asks why their heart is racing. Your options are to reassure them vaguely and say nothing, to tell them honestly what happened, to blame the nurse directly to the patient, or to wait and see whether any real harm develops before you say anything. Think about the core rule before you choose. Now let us reason through it. The correct answer is to tell the patient honestly what happened. A harmful error, and this was one, is disclosed promptly and directly, which immediately rules out vague reassurance and the wait-and-see approach, because both hide the truth from the patient. Blaming the nurse in front of the patient is also wrong, because disclosure to the patient is never about assigning fault to a colleague. So you give the patient an honest explanation, and then, separately, you report the event through the hospital's safety reporting system, so the process failure can be addressed. Honest disclosure to the patient, and a report through the system. That is the pattern the exam wants every time. That wraps up our review of ethics and professionalism for Step 3. Remember the core ideas we covered today. For informed consent, check the 4 elements, and remember that a capable patient's choice comes first. For capacity, judge the patient's reasoning, not whether you agree with the decision. For confidentiality, protect information by default and release it only for the narrow exceptions. And for medical errors, disclose to the patient honestly and report through the system. The fastest way to lock all of this in is to drill ethics questions in your question bank and read every explanation, even on the ones you get right, alongside the ethics section of a trusted review resource. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.